I am thrilled to welcome everyone to the final installment of our Best Practice webinar series, which is 2022 Trends in Digital Health and Remote Patient Monitoring. I'm Drew Schiller. I'm the CEO at Validic, and I will be serving as the moderator and maybe provide a little color commentary for today's event. First up, a couple of housekeeping items. First, we are going to focus our conversation today on trends, innovations, and opportunities for remote patient monitoring and digital health in 2022, as well as consumer expectations for on-demand services and consumer-centric experiences. Before we dive into the discussion, I want to cover a few housekeeping items. First, the webinar is being recorded and will be available on demand within about 48 hours after the event, so please keep an eye out for an email with the recording. Second is that we have a lot of time set aside to answer questions from the audience toward the end, so please submit those questions in the Q&A box. There's a chat box and a Q&A box, and it's a lot easier for us to track those if you use the Q&A box. We'll get to as many of the questions as we can, and this is an excellent opportunity for you to get thoughts from Dr. Stephen Shook, Dr. Kenneth Snow, and Dr. Nick Patel on what matters most for you. And I'm really excited about this webinar because we really truly have just a cross section of leaders here in healthcare to talk about really what's new and what's next for 2022. And so with that, I'm going to let each speaker introduce themselves and answer our kickoff question, which is 2022 will be the year of blank in virtual care. So why don't we start with you, Ken, and then we'll have Nick and then Steve. So please introduce yourself and then answer the question. 2022 will be the year of blank in virtual care.
Okay, so Ken Snow, Medical Director for Clinical Product Development at CVS Health. My background, I'm an endocrinologist by training and practiced at the Joslin Diabetes Center in Boston for nearly 20 years. I joined CVS Health back in 2014. And the question of 2022 will be the year of normalization in virtual care. That's the word I'm going to go with. That rather than this sort of outlier excuse of a different type of visit, I think it's going to become part of the normalized practice of care that's provided.
That's great. Thanks for that. Nick?
Hello, world. I'm Nick Patel. I'm the Chief Digital Officer at Prisma Health. It's the largest healthcare system in Columbia, South Carolina that spans between Columbia and Greenville. I'm also the Vice Chair for Department of Medicine. Been with the organization about 18 years. I still clinically practice, not as much as I used to, but 1 day a week currently. And I would say that the 2022 trend of the year would be optimization and consolidation, continuation in healthcare. We've seen a lot of that starting in end of 2020 and continuation in 22 and in 21. But I think we're going to see a lot of optimization of all those point of care solutions this year.
That's great. Thanks, Nick. Steve?
Hi, Steve Shook. I'm the lead for virtual health here at the Cleveland Clinic in chilly Cleveland, Ohio. And it's a pleasure to be here. I had a couple answers to this one. I think I'm going to go with, it's going to be a year for us for building digital adoption in virtual care. It really builds on what the other speakers have said. I mean, we saw a huge surge in interest early in the pandemic, and as we opened for in-person care, we saw that start to kind of level off to much higher than pre-pandemic levels. But we haven't seen it maintained at the level we expected. So we're going to be looking to tap into the interest that we saw and the passion that we saw from our patients, and hopefully we'll get a chance to talk about what that's going to look like here in Cleveland today as part of this conversation.
That's awesome. Thank you. Well, really appreciate this. Welcome all. As you can all see, we have a fantastic cross-section of both health plan, health system, little focus on the consumer side, as well as, with Prisma and actually the payer side of CVS Health, there's actually MA plan as well. So really good cross-section of speakers that I'm looking forward to digging into some questions. So first question, and I'm going to turn this to you first, Ken, which is, what is the biggest sort of shift in thinking or lesson learned with payers and providers in the last year, as we've sort of, as you said, sort of this is the year of normalization. The pandemic's kind of driven us to like this is now here. So what's been the biggest shift in thinking over the last year that you've seen?
Well, I think there's been a continuation of this consumerization of healthcare, where we recognize that if we really want to be providing care in the most optimal way, we need to recognize that we need to meet people where they are, that we need to make healthcare as convenient as possible for them, that we need to make it accessible for them. And certainly the adoption of virtual care or the expansion of virtual care maybe came about not because of the reason we all would have liked, but as we were thrown into this, this clearly demonstrated the ability that we can reach people where they are in a more convenient fashion than we have traditionally in the past. And I think that this has really become part of how certainly payers and many providers are viewing this, that there's a real opportunity here to be able to develop that rapport with our customers, patients, et cetera, and make accessing the healthcare system easier.
Absolutely, thanks. Nick, Steve, any additional thoughts?
Yeah, I 100% agree with that. There's a major shift to the retail consumer experience, and I'm sure we'll dive deeper and double click into that as part of this conversation. And one of the other things, the driving force, really spurred out of COVID is how much you can really accomplish at home and be effective and give quality care, and how much that proactive in between office care and monitoring of patients really helps you with quality and overall getting people to stay healthy and stay at a hospital.
Yeah. Couldn't agree more. Yeah, and that when it comes to social determinants of health, I would kind of add in that how much you can learn by looking in someone's home environment and what you can do with that information to enhance their care. On the payer side, I guess I'd mention that a lot of the payers that we have great relationships with, by the way, we love our payers, we're very concerned about utilization. By opening the floodgates, if you will, of virtual care, their concern was that there would be overconsumption of healthcare. And the payers that we've been chatting with, specifically the one that I've chatted with the most is our own employee health plan. We're self-insured. They haven't seen that increase in utilization. And I think there's data starting to come out from more and more sources now that just didn't happen, which I think is a huge relief, and it's going to be a huge change in the way that our payers look at what can be done. And I'd say that what's really cool is that we've really changed what we believe we could do virtually. I think this is kind of one plussing what Nick and Kenneth already said, and it's amazing what you can accomplish when you're forced to try. And I guess that would be my final comment on that front.
I think that's a really great takeaway. And just to echo that point, Steve, what we've seen in our data at Validic is that where we do see engagement from folks on the remote monitoring side, there is an increase in utilization of virtual care services, but there's a decrease in utilization of the actual in-person services. So it's a shift to a lower cost care model in general. So we definitely see that there's overall sort of total cost of care is reduced from folks in these programs. And along those lines, turning it over to you, Nick, I know one of the things that's come out of this when we talk about virtual care is really hospital at home and the shift of care from really that in-person clinic to more care in the home. And I'm curious, what do you think is next for hospital at home, and how do you think that will fit into the broader strategy for care outside of clinical settings?
Yeah, when I finished training here in South Carolina, my first job as a physician, attending physician, was a hospitalist. And what I always found was, even this is 2005, was so many patients were admitted with things that, number one, were avoidable, but number two, could be managed at home. But it took almost 20 years to get to starting to, number one, align payers to support hospital at home, but also the technology to be able to do that in a level of fidelity that is equal to the care that you receive in a hospital. You know, when we started doing hospital home, we actually started it pre-pandemic. Weren't planning it, thinking this was going to happen, but we did it because we found that we wanted to help, number one, decompress the hospitals. Number two, that we saw a trend of devices and wearables and partnerships that are occurring across the industry that allowed you and enabled you and empowered you to do this at home. So if you look at some of the top rated DRGs, disease-related groups, you know, number one things, pneumonia, CHF, cellulitis, UTI, COPD, all those things usually can be monitored at home. And so we started this program, I would say in probably early 19, maybe late 18, around some of those DRGs. And we found that admitting these patients by having the right people look at the inclusion criteria and make sure, number one, it's safe environment at home to do it, number one. But number two, giving them the appropriate equipment right out of the box. They don't need broadband. They don't need to have Wi-Fi. It's all ready to go out of a box. But having the right nursing support is key to a hospital home program. So technology plays a part, but there's still a human factor to this. So we have a home recovery nurse. We have folks that monitor and come to your house and make sure everything is going well. If you're on IV fluids, if you're on IV antibiotics, making sure that we're getting wearable data back to make sure your oxygen's good, your blood pressure is good, et cetera. And then connecting them to a hospitalist who's actually now remotely watching you over a course of 5 to 7 to maybe 10 days. But the important part of that is what happens post-acute to that. So you get discharged from the acute side, but then you're actually monitored for another plus 30 days by a home recovery nurse and escalated to a hospitalist when needed. And what we found, interestingly enough, and we've done over 1,000 of these now, and that's just out of one major health system, one hospital in the upstate as part of our 18 hospital chain. And now we're expanding it, but we had 0 readmissions. And their satisfaction score was over 95%. And if you look at the number of patients that meet inclusion criteria, the 89% met inclusion criteria. What we're doing to expand that now, Drew, is, and part of this is because of COVID, is we're all going through a surge right now. We've gone through many surges since 2020, is that we're actually doing monitor at home. And what's the difference between that? Well, instead of a hospital seeing you at home, your primary care provider sees you. So these are people who are admitted for COVID and have stabilized and not requiring more oxygen and are doing well, but don't need to be monitored, but they're still requiring oxygen and other things. And their CURB score is at a certain level that allows you to say, I can discharge you early to your house. And your primary care provider is going to, again, through the wearable kit that we give them and the tablet, is going to do a virtual visit and monitor your vitals every single day for X amount of time. And then you get discharged from that. The other piece we're doing is monitoring for observation patients, those patients that meet criteria but don't really, they just need to be observed, chest pain rule outs, things like that, that we're able to do, again, workups at home. And then we're expanding that to post-acute, where we're actually going into skilled nursing facilities and doing that as well. All of this is understanding that in order to bend the cost curve, you're going to have to try to reduce people from going in the hospital, reduce that length of stay, and reduce the readmission rate. And what we're finding is that it's much better in the old way of admit and discharge, and oh, by the way, you don't have a primary care provider, and they're totally untethered and they come back because they exacerbate. And so I think the difference here is that continuation of monitoring post-acute that allows people to make sure they have, number one, a safety net. We follow up with them and you reduce that bounce back. And then if they don't have, they're an assigned patient and don't have a primary care provider, assigning them a medical home where they can be seen longitudinally for the chronic disease, and or seeing them virtually in the future. So I'll stop there, but that's some of the things that we are doing in hospital and home. And we're seeing this emerge across the industry because it really helps. Number one, patient satisfaction, it decompresses the hospital system, and it reduces cost of care.
Yeah, that's fantastic, Nick. Thank you for that program overview. Steve or Ken, any thoughts or comments on hospital home or anything Nick shared?
Well, I think one of the things to also keep in mind is that going into a hospital is not necessarily a benign event. Um, you know, through no fault, just the fact of hospitalization. We know there are nosocomial infections. We know there are adverse events. We know that patients get confused during the middle of the night. There's risk for falls, et cetera. And all of that can be minimized by keeping people in an environment where they feel more comfortable, keeping them at home, where they know the surroundings and can avoid some of those adverse effects that are associated with the hospitalization, while still providing the level of care that they need for whatever condition they have.
Yeah, that's a great point.
In full transparency, I think hospital home is an area where the Cleveland Clinic is still learning. We see the greatest opportunities around hubs where we're already at full capacity. And like, for example, in our Florida hospitals, that is a great opportunity for us. Most of what we've done is the type of care that Nick was referring to, which would be the transitional care management, post-acute monitoring in the home, with a goal of reducing readmissions and reducing returns to the ED and just overall trying to manage utilization. And that's an area that we're really looking to grow and do much more of in 2022.
Yeah, absolutely. And this is such an interesting point, and just to sort of looking at some of the Q&A and just kind of hearing where my interest is. Just a quick follow up, and maybe Nick, I'll direct it to you. But any additional thoughts? I'm curious how are providers adopting that hospital at home? Like, how are they responding to that? And Nick, I know you and I have had conversations in the past specifically around the impending and current workforce shortage, and the healthcare burnout, et cetera. And I know you mentioned that this helps to alleviate some of that, but I'm just curious if you can sort of relate to how folks are adopting this clinically in your system. Then we'll also talk about the patients as consumers as well, but I'm curious how the clinicians like it.
Yeah, so far the hospitalists really enjoy it. One of the biggest things, we talk about physician burnout, but really it's just provider burnout, nurse, everybody involved in the care team burnout. And what we're finding is that being able to spend 50% of your clinical FTE at home taking care of patients versus in the practice is a good work-life balance, and they like it because it's a more efficient way of seeing patients. You're not waiting in the waiting room. You're not waiting for 10 things to happen before through the nursing intake for you to see them. You're not working through just 3 rooms. You're able to see more people faster. And so I think there's an efficiency play and a satisfaction from at least from the physician standpoint we've seen. Now, you might have also seen in healthcare IT news and other things that there are some major healthcare organizations who've introduced this concept, and the nursing union have said, hell no, don't do this. I don't want to do this. This could potentially take jobs away from nurses. But that has really quieted down because there's no shortage of job openings for nurses across this country. So I think that it takes, just like the pandemic really was a catalyst for virtual health, and half our providers, probably more, 75% probably like shrug their shoulders or put their noses up to virtual care pre-pandemic. But now like, wow, I actually like this. And there's American Hospital Association document that just came out for about 2022, and they talked about this, and they said that 48% of providers would like to continue using virtual care as part of their care delivery in the future. So I think that we're going to continue to see this, and overall, so long as we don't penalize people for working from home, and we enable them to work from home, and we're not asking you to go buy a very high power computer, and we enable them with the hardware they require, the broadband they require, and those are not going to be out-of-pocket expenses for the provider at the end. And I think that overall we've seen a good adoption. Now, the key to that, though, I will caveat this with asterisk, that there has to be a linkage to a brick and mortar. There's got to be a linkage to the rest of the team, because you can't do everything digital and you can't do everything virtually, right? So there has to be a way to escalate people to a brick and mortar location or labs and ancillary services when those things are needed. And that needs to be seamless as part of the workflow. So workflow is extremely important as part of this for the satisfaction. We don't want a repeat of how EHRs have caused burnout to most of the providers.
Yeah, I totally agree with that, and maybe to continue on that thread a little bit, because I think that's such an interesting point. I'm curious, maybe Steve, how has your organization's view um, around these sort of virtual remote patient monitoring strategies in healthcare changed since before the pandemic to today? Like, what's been the sort of mindset shift that you've seen inside your organization?
Sure, absolutely. If I can set it up though, because I looked up the statistic while Nick was giving his answer, I wanted to make sure I had these numbers right. So with regards to provider adoption at our organization, and we've been doing this since 2014. So immediately prior to the pandemic, only about 15% of our providers were doing virtual care. And of course, in April of 2020, it was 95%. And but now, it's settled back down around 75%. So clearly what you see, and at the clinic, I mean, we've taken the approach that we've let the patients dictate how much digital access and virtual access we're going to provide. But we've also given the flexibility for providers to decide how much of that demand they want to absorb within their clinics. So we've tried to balance it. And so there's clearly a trend toward our providers wanting to continue to have at least part of their practice remain virtual. So if you'll forgive that, then I'll answer your actual question.
No, I
So
think that's right in line with it. Yeah.
yeah, the other possible answer to 2020, well, the 2022 will be the year of that I could think of would be scalable RPM solutions. At the Cleveland Clinic, we've had more of a science fair approach to remote patient monitoring solutions. It's been one really cool little thing over here and another really cool thing over there, but no really centralized strategic approach to bringing this all together in a way that helped us perform better on value-based purchasing contracts, for example. I mean, all the things you want to see. And I think, part of that obviously is the complexity of billing, the complexity of reimbursement, and anyone who out there who's tried to bill for remote patient monitoring in a fee-for-service kind of environment knows what I'm talking about. But I mean, just as an example, pre-COVID, we continue to have a really cool program for our lung transplant patients where we're able to remotely collect pulmonary function testing, which is an early predictor of lung transplant failure. A very successful program that has had a huge impact on outcomes in that small group of patients. And yet this huge group of patients that we're discharging from the hospital with CHF and COPD, to say that we've really cracked the nut on consistently identifying patients that are at the highest risk, giving them devices we think that will help predict early their return to the hospital, we just haven't got there. I mean, we have a COVID home monitoring program very similar to what Nick mentioned, and I think that we've learned a lot from that. And we're very, very excited about doing things in a more scalable way. And what we've realized is that we need to really put together some shared resources around doing remote patient monitoring with a centralized administrative function, a way to collect those minutes for when we need to bill in a fee-for-service way that makes it a non-manual process, and really kind of build a center of excellence around remote patient monitoring that all of our institutes and clinical centers can tap into, rather than trying to do a little bit over here and a little bit over there. So I think that realizing that to really unlock the potential of that, we need to bring it all together in one place with a central strategy was one of the key things that we determined out of necessity.
Yeah, that's a great point. And Ken, I saw you nodding emphatically. I'm curious if you had any points or any thoughts to add there.
I was just thinking about any provider. It's challenging enough just to get through your day from an administrative point of view, making sure that the charts are done, the paperwork or the electronic paperwork is taken care of, and that there's a bill generated at the end so that you or your organization can get paid for the work that you just did. If we do not make that seamless and easy for providers in a virtual world, then it's just not going to happen. It's not surprising that adoption pre-COVID was very low, because if I'm going to do this once a week, this is a nightmare. because by the time I do my virtual visit again, I'm going to forget how it was that I actually got through my virtual visit. My Zoom won't work, the billing won't work, right? And I'm going to repeat this every single week. Whereas if I'm doing this as a significant part of my time, then it just becomes part of my workflow. And if the tools are there to make it easy, or to make it easier, then that's going to facilitate the process.
Yeah, Nick, go for it.
I saw this comment that in the chat that I think is important that we address, and as we talk through this, is empathy. I think that person raises a great question. You don't want to end up being air traffic control to your patient. You have to realize that is your patient and you're responsible for that person. They put their lives in your hand. And I think that's something that is hard to do sometimes if you're only doing it virtually. It's always, to us, I don't think brick and mortar is just going to go away. I think that what we have to start thinking about is that healthcare can be rendered outside of the office as equally as it can be in the office. So historic medicine, right, over centuries has been the only time you get care is when you see a provider in a location, right? But now the shift has to be that, again, and that turned out to be a very reactionary healthcare system, hence our costs are so high. And now we're looking at more proactive care. So it's not that I see Drew as a patient and he's got hypertension. Hey, Drew, I need to get better. I'm going to send you home with a digital therapeutic type device here that's it's not going to treat you automatically, but it's going to give me enough data to then I can react and change your blood pressure medicines or give you input in between your 3-month, 6-month follow-up. Because why should I wait 3 months or 6 months to see you and you have blood pressure that's high for 6 months? So I think the definition is that the empathy needs to be very front and center, that, this is not a replacement of you sitting next to your patient and having hard conversations and building that rapport, but it is a tool that is going to help you get them to their goals faster. So I appreciate the question around empathy.
Yeah, I think that's a really great point. And, one of the individuals who has gone through a diabetes program that Validic helped to power with one of our health system partners, he actually, when he got enrolled in the program, he had uncontrolled diabetes for a decade, and it's really challenging. And once he got enrolled in the program, this is getting back to your empathy comment, Nick, was that his provider interactions before that were, quarterly going in for his checkup and having his A1C test and having it be, having it fail, right? Having it be over 9. And every time hearing, you need to eat healthier, you need to exercise more. And he's like, I'm trying to do that. He got enrolled in this remote monitoring program, and now all of a sudden the data is there for his daily glucose readings, as well as he could add food notes, etc. And what they found was that his glucose kept spiking between 7 and 9 at night, but he wasn't really logging any different activity. And when the provider was able to sit down with him in person with his virtual data and say, hey, what's going on between 7 and 9 at night? He's like, oh, well, I'm sitting down with my wife and we're watching Netflix and I'm eating popcorn, but it's, no butter, no salt. Like it's healthy, right? It's like no calories. And it turns out that was causing his glucose to spike. And so he cut that out based on that conversation, where the conversation was now about the data, not about him not doing the right things, right? It was the conversation about the data. And within 30 days, his A1C dropped by 0.5 point. And so these data can be really, really valuable for those in-person conversations. I think that's just a fantastic point. Yeah, thank you so much. And I'm curious, so we are getting a ton of questions around reimbursement, and we have a very interesting sort of mix of folks to fee for service, value-based care, more on the health plan and consumer side. I'm curious, and maybe I'll start with you, Nick. And it's sort of talking about this, but in what ways do you see the roles of health plans and health systems sort of shifting in 2022 and beyond? How are things starting to come together in your mind in order to make this something that's more fiscally fiscally solvable as a healthcare organization, as a healthcare industry?
Well, I think first of all, we got to get fee for service out of here. I think that's just not, it's not, something that's sustainable. And I think a lot of this move, even though it's reactionary, and people say we're doing it for our patients, but it's also trying to bend the cost curve to reduce admissions and get people to goals. Because finally, payers have decided, oh, wait a minute, we're paying you for a service, but it doesn't matter what kind of quality you give. But now we do. So value-based care and at-risk contracts are here to stay, and they're going to continue to grow. I've been with the organization 18 years and been talking about it for 18 years, but I tell you, it's amazing to see what has happened in the last 5 years. I mean, we have a huge number of patients and hundreds of thousands that are in some sort of shared risk program. And so when you start to look at it, that it's not about just putting an E&M charge and putting a code in so I can get reimbursed for RPM, but it's more about making sure that person gets to their goal. And yours was a prime example of that. That particular person could have ended up in a hospital in DKA if their sugar continued to go up. So who wins in that? Nobody. And so I think part of it is that, yes, there are actually reimbursements around this, and I won't go into all the details, but essentially under EUA, it's actually lessened it, that you don't have to have 16 days worth of data. You can have, I think, 1 or 2. I mean, it's not even that much. But it's also, as your great example, let's just say you did that totally virtually. That's an actual E&M charge for that visit that's currently in America getting equally paid as an office visit. And so we don't know where that's going to shift. Maybe virtual visits be 80% of office visits. I don't know. That's up to the guys in DC to decide. But I know everyone's lobbying to keep it equal, because the resources have to be there on the back end to support all this stuff. But I think the key here is understanding is how we're going to bring more value to the patient and get them quality care. So is it a take money out of your left pocket, put in your right pocket? To me, it's all about what that shared risk model looks like. So there, you have to make a decision as a health system: are we doing this because of our bottom dollar? Part of it has to be because you have to be solvent as a health system. But number 2 is, if we're taking so much risk and we just started our health plan, well, we need to make sure that they stay healthy and they stay in the ambulatory space or they stay home. And in order to do that, I have to be able to provide care when and where they live and how they live. A guy's sitting watching Netflix, eating popcorn, I should know about that. And that I should react to, not 6 months or 3 months later, but real time.
Yeah.
And I think that's where the difference is. Yes, there are codes for these things, and they're out there, and we've done them, and we get reimbursed for them. But I think you have to think about what the end game is. If your end game is to keep people healthy, and they're also part of bending the cost curve for your health plan, your at-risk patients, then you're gonna win in the end either way, either through hard cash coming in from payers, or in the downstream revenue cost savings from saving people going for the hospital or getting chronic kidney disease and heart failure and reducing strokes and heart attacks. So it's a balancing act of which way you look at it.
Yeah. And thanks for that, Nick. And Steve, I know, Cleveland Clinic is very much in the fee-for-service world. I'm just curious, how are you thinking about that right now? It is a bit of a challenge, right?
Yeah, I mean, we do have patients at risk, and I guess I had imagined that where we would start with our remote patient monitoring scalable work would be with diabetes. We already have some really nice smaller programs that we could build on. But what I learned for us was that, at least in our ACOs and in our patients at risk, we were already doing a really good job managing those patients for the most part without RPM. And that there wasn't as much bang for our buck there. I mean, in those patients, it's all about utilization. It's all about hospital admissions, readmissions, ED visits. So it really changes the focus for us at any rate. So the work that we want to do in diabetes, actually for now, I mean, we are going to need to be able to collect, because I saw a question fly by, well, do you really care about the fee for service stuff right now? At our organization, we do. I mean, at least for now, but we do understand the long-term play, to Nick's point, absolutely is going to be delivering value. There's no doubt about it. It's just that in the meantime, we need to be able to get paid for the work that we're doing. I mean, we, gotta have the ROI, where you can. You can't lose money and go out of business before you realize the whole vision of value-based care.
Yeah, absolutely. Yeah, that's a great point. And I think, to maybe pulling on a thread of what Nick said around the reimbursement code specifically, is that one of the things that we often find with health systems that we talk about as they're looking at the remote monitoring reimbursement codes is that, you know, the 99457, which is the code to review the data by a clinician, it's about $50 reimbursement for 20 minutes in a 30-day period. But you can also, but that includes you have to have a telephonic component. And today, at least during the public health emergency, you can do just a 7-minute visit for level 2, level 3, and get, a $90 reimbursement. And so, since you're going to be on the phone with that person anyway, probably makes sense oftentimes to use the data to just help drive a better conversation and bill in the traditional way. And Ken, I'm curious, CVS Health such a super interesting cross section here. Like, what are your thoughts? I mean, in some ways you're the savior, and in some ways you're sort of, I'm sure, seen as part of the challenge, right? So,
Right.
how do you think about this?
Yeah, so it sometimes I think schizophrenically about it. So as as a provider of care, if we talk about minute clinics and virtual care, then we're going to align, as any provider of recognizing that we're still in this world of fee for service. We need to transition out of it. That's clear. And it provides an opportunity, particularly for us to partner, let's say, with PCPs in the community, that we can provide that additional help through RPM to play that intermediate role in between visits. So you're not, your blood pressure was high 6 months ago, and then 6 months later is the next time it gets addressed, as opposed to why isn't it addressed every couple of weeks? Or, you got started on insulin. Why is your first dose adjustment going to occur in 3 months? Couldn't occur next week or in 3 days. So there's that aspect of it. Now, we also sit on the payer side, since Aetna is a CVS company after acquiring back in 2018. And so how we pay for this becomes a great issue. Would we love everybody taking risk? Absolutely. Because when we do, then we're looking at outcomes, which is ultimately what we care about, are people doing better. If they're doing better, then it makes sense that we're using this technology. If they're not doing better, or if a particular patient isn't going to do better with technology, then it's kind of a waste of care. And does it really, is it really needed for that person? What I don't want to see this moving into, but it's kind of out there and we dance around it a little bit, is RPM is a great tool for those who benefit from it, all the examples we've mentioned, but there is the potential to, hey, let's slap every person with diabetes on, the following 5 devices. And hey, let's do this for everyone with CHF, regardless of whether they're stable, not stable, whether they've been admitted 4 times, or whether they're on their stable meds for the last 5 years and are doing great. And when you do that, because that does generate income, then of course payers respond the way that you would expect payers to respond. We'll put more rules in, saying, oh, well, here's the list of things, and we'll cut reimbursement. And then, of course, the response from providers is, well, then we need more people on it because now we're not being paid as much. And we get into this horrible downward spiral of, ever increasing regulation and less payment for more work for people who don't necessarily benefit. So we want to avoid that from ever, really getting started. We've done that before in other areas in medicine. Let's not do that in this one. Let's keep this, outcomes focused. Which patients, whether they're being paid through a risk contract or whether they're being paid for fee for service, which patients are actually the ones who are going to benefit, and let's make sure that those are the folks who have access to this type of care.
Yeah, it's kind of a double-edged sword, right, Ken? If you put everybody on there, then you're thinking about the actual medication costs and everything else that comes along with it. But just one quick last thing I'd like to add, though, and it spurred a thought from another chat comment, is is we have to really incentivize. Value-based care is really incentivizing the health system to keep people healthy, but we also need to incentivize the patient to be healthy. And being an internist for 18 years, sometimes you can tell a patient everything, that they're going to go blind, they'll lose their kidneys, and they'll like, okay, well, I'll wait till it happens. And it's just a reality of what we deal with. And so we have to think about, how do we incentivize the patient as well? A part of it is some of the things that we're looking at is the gamification of healthcare, where you're taking your med adherent and you're taking your readings for RPM. You may get a reduction in your premium. You may get a gift card to something, just a little something, without breaking any Stark laws, to make sure that you're actually incentivizing the patient to be healthy. And because a lot of these things are silent killers. Diabetes takes a long time to kill you. Blood pressure takes a long time to kill you. And people don't realize that, just because you feel fine, but your blood pressure isn't, or your sugar's high, doesn't mean that it's going to vote well for you in the future and cause, blindness or kidney failure, or non-traumatic amputation, all the things that happen with these things, or strokes or heart attacks. And so I think there, as part of the conversation that we're trying to think about, and we haven't figured it out, is how do we incentivize appropriately the patient to be more adherent to all these things that we're trying to do to keep them healthy?
Yeah, I think that's a really great point. And it's oftentimes in chats like this that I think about how healthcare at the end of the day is really people helping people. And sometimes when we think about the healthcare industry, we're using this is the way CMS looks at it, right? It's like they have a very blunt instrument and they try to apply that blunt instrument in a way that's going to help the most people possible. But at the end of the day, there are some people who get enrolled in a remote monitoring program, and we've seen this in our data, who are just thrilled to have a program where they're in it with their providers and there's a common goal and that they have some help, right? And then there are others who are like, don't put that device on me, I'm not interested.
Right.
And so how do you sort of bridge that gap? And I'll say maybe just we could talk really quickly about that consumer aspect of it. Is that coming off CES was last week, we're seeing a proliferation of continuous health sensors, right? Very passive sticker sensors that can get 60 hertz data, continuous glucose monitors that bring in a lot of information, as well as sort of other more passive data elements. Do you think that that is something that will help? And this is maybe more of a general question to the group, Nick, Steve, or Ken, but what are the things that are really going to help drive that consumer adoption? And one thing I'll add to that is, in the same way that we're on Zoom right now and not on a live panel at a conference, we've shifted to a virtual first environment. And I think people see that in healthcare or in anything, right? In any interaction. They expect to be able to access their providers via virtual and in person. They expect to be able to access their car dealer virtual and in person, right? Whatever it is, like there's got to be this hybrid. So I'm just curious, what are the thoughts around how do we engage consumers today, and what's different about that moving forward?
Yeah, I love this question because it's something that I do a lot of thinking about, and I was supposed to be at CES to see some of this, and I saw it my last time I was there. Is that really, in order to build adherence, it needs to melt away into your environment. It needs to just be part of what you do. You put your shirt on. Imagine a shirt, and they showed at CES that checks your blood pressure, how's your heart rate, because it has sensors built into appropriate areas of your T-shirt. Or you're brushing your teeth and you're standing on this mat that tells you your weight, right? And so as you touch a faucet, it tells you body fat composition. It needs to be just part of what you do. So when you take use the bathroom, it analyzes that. I mean, there's companies that are actually working on this where it then just blends into your environment. Of course, that you also have to think about security and people feel that their privacy is invaded. We can't, again, we need to have full consent. We need to make sure that the data is used appropriately, and we can't penalize patients, because sometimes patients are like, well, I don't want my doctor to know I have hypertension, or I don't want everyone, my insurance to know this. Well, technically they know because of claims data, but and so data sharing is important and understanding who's getting that. You don't pharma to get it and all these types of things. But I think the key to adoption is, number one, make it cost effective and not nickel and dime the patient. It needs to be covered by the insurance. And number three, it needs to be something easy to use and to a point where it's wearable, a true wearable. We talk about these are all wearables, but they're not true wearables. You don't walk around with your blood pressure cuff on your arm, right? Or walk around with your stand on the weight scale. So I think they really need to be a point where they're just part of our lifestyle, just like we put our Apple Watch on and you get data, and that's all there is. But it's a watch to me.
Yeah.
I think there also has to be the aspect of, what does the consumer of healthcare want out of this? So I agree that it has to be, everything that Nick just said, about being, present and easy, et cetera. But also, what's the ultimate goal of why do I want to wear this stuff? And the answer may not be, because you'll be healthier. I mean, for some people, that is the motivation. That's why I go to the doctor, because it's the right thing to do. So I go to my doctor's appointment. But we know that there are people who are like, well, I'm not going to go until I feel sick. So we have to start thinking about, what are other reasons why people will do this? How does it make their life easier? How does it make their life better? What kind of value does it add for them as the consumer of healthcare, and and we can't only focus on what's the long-term outcome. Well, this will keep them healthier, and expect that to be a motivator for everyone.
That's a great point. Any thoughts to add on that, Steve?
Well, I think about our employee health plan, and our rates are determined by exercise minutes and steps walked. I know a lot of employee health plans, a lot of plans out there are trying to encourage you to not only monitor yourself but hit certain goals. And if you can do that well, I think that you can be successful. I know that in talking with some organizations that seem to do this better than we do and have a lot of success, they tell me that they go into people's homes and talk to them, and they see multiple devices that have been given to them by their insurance companies or various health providers that they've worked with that aren't even opened, because to the point that Kenneth and Nick made, they just didn't see the value in doing it. So I think if you can, for people that are paying for their health insurance, through their employer, that could see that's an obvious potential motivator. But those who aren't, I guess you got to figure out either how to make it a habit, to Nick's point, or you make it fun. I mean, you think about, like, why do people go on Facebook or use a lot of these time-wasting idle apps? They keep going in and, like, I don't know, adding another room to a house or something like that on their phone. There's some kind of gratification when they do that. I think if you can make being healthy fun and engaging, using devices that people are already using, you give them achievements and awards and let them communicate and share their progress with their friends, you will probably be a lot more successful. So we've got a lot to learn from areas outside of healthcare that are already doing this well. Fortnite for fitness. I like
that. There you go.
Drew's going to be on TikTok with a blood pressure cuff on after this meeting.
Exactly. I love it.
The other thing is, we're going to have to figure out what should we be measuring? Because it's just there's a lot of stuff we now can measure. There's an explosion of what we will be able to measure. And then there's the question of, yes, but what should we be measuring? Which of these actually contribute to better health, and which of them are, just the, gee, that's interesting. It's like driving an automatic car. I'm not shifting, with a tachometer in it. Well, now I know how many revs my engine's doing. That's nice, but why do I need it? Why do I care? Why do I need to know that? In a day where I shifted, it was helpful. In a day where it's shifting for me, I don't care. So this is true in healthcare devices as well. What are we going to, what kind of information are going to prove to be of value that either the patient's going to be able to utilize that data and improve their health, or their providers will be able to utilize that data and make decisions and change their health? And what else is just going to be, gee, that's interesting, but doesn't really make a difference in how well people do.
Yeah,
Can I
I
just
think that's right on.
throw in too?
Please.
I was thinking about this in terms of weights and blood pressures and pulse rate and steps and stuff that's boring and maybe a little harder to sell. But to the point that was made by both of you, for patients that have chronic disease, and I should have mentioned that I'm a neurologist, I guess, as part of my introduction. So, for example, patients with Parkinson's disease, there are smartwatch things out there now, and we've got some things we're working on at the clinic that allow us to monitor tremor and speed of movement and activity. So when patients see the ability for us to do what Nick mentioned earlier, which is be proactive and call them and say, hey, we noticed that your tremor's worse, or we noticed that you're not moving around as much, you're moving more slowly. We want to adjust your Cinemet before you come back. I mean, I think when patients see that we're actually using the data that we're collecting to take better care of them, that for many patients with chronic disease, that may be pay off enough by itself, but maybe not for everyone.
Yeah. No, totally. I think it's dead on. And, I think what we will ultimately find out, at least what we see in our data, and we have, 5.5 million people in across all of the programs that Validic supports, is that it's actually, a relatively small amount of data per person that's really needed to develop a trend. And those trends are extremely insightful, as opposed to, having like, it's not like a F1 car where you have to have 1,000 different sensors in order to like tweak everything in a moment's notice, right? So I think it can be a lot more straightforward than sometimes we sort of let ourselves think. And so I'm curious, maybe as we're kind of coming toward it, and we had a number of questions come up around scale and like how to actually roll these programs out. And I want to kind of combine that question with a little bit of the conversation that we had around the regulatory environment. And maybe Steve, will start with you, but I'm curious to hear everyone's thoughts on this. Like, what are sort of the barriers to adoption, both clinically as well as like what would you like to see from regulators? How can they start to help really enable these programs to scale successfully?
I asked the folks that have done more work with this than I have in remote patient monitoring for longer, what they thought of it. And they were very quick to say that, regulation hasn't necessarily what's stood in the way of seeing more remote patient monitoring work. I mean, certainly for virtual health in general, there have been limitations. And I think reimbursement, as I've already alluded to, state licensing, issues that prevent us from reaching further and, helping more patients are two examples that come immediately to mind. So solutions around those would be incredibly helpful to, allow us to do more with the types of things that we want to be able to do. And, we do a lot with advocacy. I mean, we talk to payers, we talk to, government payers, and I think the fear in the examples we always hear are it usually comes back to fraud and overutilization, as I alluded to earlier. So what I would ask is that every time that they start to see fraud, that they look at it very carefully and ask themselves whether it was truly the digital or virtual nature of that care that
Right.
was at the root cause of the fraud. Because you see these examples in the news and CMS and blah, blah, blah. But, honestly, some of these bad actors that are out there, and fortunately, none of them are on this call, I'm sure, at all. But those folks that are out there that are going to create these concerns are going to do it whether or not the care is
Billing
virtual.
fraud did not start with virtual care.
Absolutely. And we have robust systems in place to review these charges. And so I guess I would just ask the regulators to keep in mind that you need to compare apples to apples. And I think what they're going to see, and what I think we've seen so far, is that when you open up digital options and you try to make it part of your care model, fraud doesn't increase. I mean, that would be my initial thought.
That's great. Nick, Ken, any thoughts?
Yeah, I agree. I think the regulators have been, obviously there needs to be some fine tuning of the rules and regs around this, but they're not the major hindrance here. I think the biggest piece is, RPM comes in so many flavors, right? So there's the ones that you give to chronic care management folks and that you base on data and you send the home devices mostly from the practice side. Then there are people who are wearing them just because they can, to get Fitbits and Apple Watches, and they're trying to stay healthy, or sometimes a health plan is giving it to them directly. And then there are services around RPM that actually do everything from A to Z, to give you the device, to call you all the time, and give you a connected tablet. The cost is a big issue, I think, is like, reimbursements, there for, I think there's a chart, I forgot the code, but there's a tech fee that for the initial one.
99454.
Yep. And that allows to cover some of that cost. And we've actually been very successful in partnering with American Heart Association, who wants the same thing that we do, which is improvement in outcome of hypertension, diabetic patients, CHF, et cetera. So you're actually supporting giving some devices. But one of the things is that, and Drew, you and I have talked about supply chain management and logistics. It's not just something that health systems do really well. We do it for bed control and sheets and all that kind of stuff, and keeping our PAC system and everything ready. But the thing about it is being able to ship a device to a patient or a population of patients is not something we do well. And so I think that making sure that is easy, the easy button for that, and if they can make the cost lower for these devices, because going through the FDA process and all these things is not inexpensive, and it takes a lot of time. And so these companies are trying to recoup some of that. And then also, just in COVID, supply chain in itself is hard, right? You see chip shortages, there's a shortage of everything. So costs in general have gone up, but the reimbursement has not gone up. Today, CNBC reported inflation has gone up 7%. Well, did my reimbursement go up 7%? It didn't go up 7%, right? So, but the cost of the devices and everything else has gone up, and even staffing costs have gone up. So how do you stay solvent in all of this when you're trying to do something for the right reason? But I would say to the regulators is that they need to keep a very close pulse on the market, understanding what health systems are moving to with this value-based care, and then they need to be able to support that and really make it easier for a point of entry for small community hospitals, right? We can do this because we're a large system, and Cleveland Clinic and CVS can do it because they can because of the size of their organizations. But a community hospital that is, again, probably one of the based on social determinants of health, is probably where a lot of this disease is in a small community. So how do you make sure that you keep a fair playing field for all your providers?
That's such a great point. And I know we're coming up on time. Ken, any final thoughts on this?
Just to add the aspect of privacy on this, which we've touched on already, there's going to be an explosion of information moving around. And certainly we need to protect people's privacy and the privacy of their information, but we also have to sort of be cognizant of the potential for overregulation, sort of the pendulum swing of, oh, there's too much information, and so let's make this impossible to move, information around, and then, which can negatively impact a lot of the value that comes from this, is the ability to bring in different sources of information, and bring that information together and get a better picture of the patient. So we need to be careful of not over, stepping in privacy, but on the other hand, not over regulating it either.
Mm-hmm. Absolutely.
Well said.
That's such a great point. Thank you. And with that, I know we're a minute over time. Thank you all to my panelists, and thank you to the participants. We had great chats and questions come through. So thank you for that. We will be following up with a recording after this. And if there are any questions that didn't explicitly get answered, we will follow up separately and try to get as many of those answered as we can. So thank you, Ken, Nick, Steve, really appreciate it. Happy New Year. Hope 2022 is fantastic for you all. And I look forward to talking soon. Thanks, everybody.
Thank you. Thanks, everybody.
Talk soon.